Hello, this is Dr. Joanne Manson, Professor of Medicine at Harvard Medical School, Brigham and Women's Hospital. I'd like to talk with you today about the subject of hysterectomy for benign disease and the relative merits of ovarian conservation versus bilateral oophorectomy. Recent studies have shed light on this very thorny issue of whether or not to remove the ovaries when hysterectomy is done for benign disease. A recent paper was published in the European Heart Journal. It was done in Sweden, a large population-based study that included more than 184,000 women with hysterectomy. And they were followed with registered linkage for cardiovascular hospitalizations. This study suggested that women who had hysterectomy with oophorectomy done at a younger age, before age 50, did have a significant increase in both coronary hospitalizations as well as stroke, about a 40% increase. Even women who had a hysterectomy without oophorectomy had about a 15 to 20% increase in cardiovascular hospitalizations. These findings of an increased risk of cardiovascular outcomes in women with bilateral oophorectomy before age 50 are very similar to our findings in the Nurses' Health Study that we published in Obstetrics and Gynecology in 2009. We followed more than 29,000 women in the Nurses' Health Study who had hysterectomy, and the women who had hysterectomy with oophorectomy had a significant increase in all-cause mortality as well as coronary heart disease. It was relatively modest in the overall cohort, but among the women who had hysterectomy and bilateral oophorectomy before age 50 and were not treated with estrogen, there was close to a doubling in the risk of heart disease and stroke and about a 40% increase in all-cause mortality. So overall, these studies do raise concerns, particularly about hysterectomy with bilateral oophorectomy done before the age of 50. And whether or not hysterectomy alone increases risk of vascular outcomes due to maybe some disruption of the blood supply to the ovary, I think remains unclear because of a large number of potential confounding factors for hysterectomy, including obesity. But with bilateral oophorectomy, there does appear to be strong evidence of an increased risk of cardiovascular events, suggesting that in younger women who have hysterectomy for a benign disease, bilateral oophorectomy should be avoided if possible, and when done, serious consideration should be given to estrogen treatment at least until the average age of natural menopause. It's important to emphasize that these are findings for women at usual risk. We're not talking about women who are at increased risk of breast cancer or ovarian cancer, strong family history, BRCA gene positivity, etc., where often the benefits of oophorectomy will outweigh the risks. But these findings suggest that for women at usual risk, bilateral oophorectomy at a younger age does appear to be associated with an increased risk of cardiovascular events. Thank you very much. This is Joanne Manson.